Good evening, everyone. I am Dr. Murali Chand from India. Today, I am going to present a case of laryngeal inlet pathology, multiple laryngeal papillomatus, almost obstructing the laryngeal inlet. So there is a term called in anesthesia, no intubation, no ventilation. That is a real crisis. So, in all laryngeal pathologies, which are almost obstructing the laryngeal inlet and subglottic stenotic cases, you have to be very careful. You may face a situation called no intubation, no ventilation. So, that means it's a crisis. No intubation, no problem. You just keep a face mask and observe the chest, and if the ventilation is going on very well, that means the chest rise is there, not at all a problem. Patient will survive. This after giving scoline. So after giving scoline, if you face no intubation, no ventilation, it is a crisis. There are so many reported deaths after giving scoline. When you cannot intubate, when you cannot ventilate, immediately you have to do cricothyroidotomy and pass the ET tube or anything through this, and immediately you have to connect the boils, oxygen. So let me explain in detail. So when you anticipate no intubation, no ventilation problem before giving scoline itself, for example, in a clinical situations of laryngeal inlet pathologies where almost obstructing the laryngeal inlet and subglottic stenotic cases, you have to be very careful. Then you should not give scoline. Once you give scoline in these type of pathologies, it is crisis. Death happens. So immediately you have to do cricothyroidotomy and pass the ET tube through this. And another thing, even though you are an ENT surgeon, you should know this no intubation, no ventilation problem in your clinical situations. In sleep apnea conditions also, where there is tongue based problem also, or large oropharyngeal masses also, you may face no intubation, no ventilation. Simple no intubation, there is no problem. You can apply face mask and you can ventilate. Even after giving scoline also, you just apply face mask and patient will recover. That scoline will taper. So in these type of cases, how to prevent death? Once you face first of all, you have to anticipate these situations and be prepared with tracheostomy and the certain things I will tell you. How to manage this crisis. First, let me tell you how to manage this crisis. Immediately cricothyroidotomy has to be done and ET tube has to be passed through this. That is immediate. And another thing is, like this is makeshift tracheal oxygen cannula, like this, simple needle, large bore needle, and 5cc syringe and connector, which can be connected to the boils. Directly you poke here and connect to boils, and immediately it will be ventilated. And another thing is, high flow humidified oxygen has to be passed before itself when you anticipate it. So I will explain that what is high flow humidified oxygen. But none of these is a replacement to emergency tracheostomy. Immediately what you have to do is, this is a needle, this is blade. Immediately you have to poke like this, emergency tracheostomy, and reverse it, pass it like this, pass it and rotate it. Then you will get a gap. So like this, give stab like this, and immediately reverse it and rotate it, make it vertical. Then you search for ET tube. So by rotating like this, you are getting a space and you can keep some oxygen here. So immediately you have to pass a ET tube here. So crisis is really panicky situation. So you have to prevent it. So in this no intubation, no ventilation problems, especially sleep apnea situations or laryngeal inlet pathologies or subglottic stenotic cases, you have to keep, we have to prevent this. You have to keep a high flow nasal oxygen cannula, high flow nasal oxygen cannula inside it. It will increase the apneic time. How to do that? I will explain. High flow humidified oxygen cannula. Simply you can connect 10 liters or 15 liters our routine oxygen thing, oxygen humidified oxygen, which we connect to boils and everything, and which we keep nasal cannula in ICUs. Water will be there and the liters parameter will be there. That you can immediately keep in the nose, nasopharynx. That will increase a little bit of apneic time. I will show videos also that when you anticipate the situation, keep a high flow nasal cannula. And there is separate instrument also for this high flow nasal oxygen cannula. That I will show you later. So when you don't have that instrument, high flow nasal cannula instrument, you can keep a simple our routine ICU setups. You will have water and liters parameter, and that you can connect to nose. At least that will buy some time. I mean, it gives some more apneic time. So when you anticipate this no intubation, no ventilation problem, one, keep a high flow nasal oxygen cannula. Immediately you have to be ready with the cricothyroidotomy. And another thing is this one, needle. So you have to be prepared with all these things beforehand itself. And regarding anesthesia technique, in this when you anticipate these situations, no intubation, no ventilation, don't give scoline. You have to do a technique called spontaneous ventilation. That means the patient is not going into the deeper planes, and he is becoming calm, and he is maintaining his oxygen, 100% oxygen with his respirations. So the drugs we give is propofol. Some anesthetists they choose propofol and fentanyl, and some anesthetists they choose propofol and dexmedetomidine or dexmedetomidine separately. You can ask your anesthetist how they will perform that. That is called spontaneous ventilation. That means the baby or the child who present with multiple laryngeal papillomastosis or the adult with sleep apneas, they become calm. See, in our sleep apnea, this one, sleep study also, we give propofol. That is called spontaneous ventilation. So, in child with multiple laryngeal papillomastosis also, we have to do spontaneous ventilation. Never give scoline. That is very important. Death may happen if you don't notice this, no ventilation, and you are unable to do intubation, death happens. You have to be very careful. So now spontaneous ventilation, you have to intubate. That means the patient becomes calm and immediately you intubate it and give vecuronium. No need of scoling. So that is how we have to manage a clinical situation. Now I am going to present a case of multiple laryngeal papillonosis in a 5-year child. So how we have done is, we have given propofol and fentanyl, and child became calm, and the child is in spontaneous ventilation. We are anticipating no ventilation, no intubation. 1 minute. So for this spontaneous ventilation, anesthetist uses inhalation anesthetist. One, this sevoflurane, and that is first choice, or whatever it may be. That is first choice. My anesthetist told that is first choice. If that is not available, they will select propofol, and that is second choice. And the third one is dexmedetomidine, or whatever it may be. It depends upon the experience of anesthetist. So you ask your anesthetist how they will perform spontaneous anesthesia. So the three modalities, three drugs are inhalation anesthetics, sevoflurane, and propofol, and dexmedetomidine. And that depends on the anesthetist choice and his experience and other things. When you don't have inhalation anesthetics, you can use propofol, and some anesthetists they use dexmedetomidine. You ask your anesthetist. Thank you. So this in a child of 5 years, child with multiple laryngeal papillonosis, almost obstructing the laryngeal inlet. So we are anticipating no intubation, no ventilation. So what we have given is propofol with the fentanyl at minimal doses to maintain the spontaneous ventilation, and anesthetist intubated without giving scoling. So scoling should not be given. The patient is survived because the patient, the child is in awake situation, fully conscious. That's why the child is surviving. Suppose if you give scoline, that means if the laryngeal inlet pathology, multiple laryngeal papillonosis, if it obstructs the laryngeal inlet, it's a crisis. The patient will die. You sometimes you cannot ventilate also. Immediately you have to do cricothyroidotomy. If you cannot anticipate that, it's a crisis. It's a death. So before it hand itself, in a 5-year child with multiple laryngeal papillonosis, what we have done is we have given propofol and we intubated when the child is in spontaneous ventilation. We have not given scoling. And then we have given vecuronium. Then we kept endoscope or direct laryngoscopy under microscope. We removed the multiple laryngeal papillonosis. But we are prepared with all these things: high flow nasal oxygen, emergency cricothyroidotomy. See this one. We made this ET tube also, small ET tube, 3.5 size, and we cut short this. This is a very lengthy one. We cut short and make a small ET tube to pass the baby like this immediately. So we shortened this. When you don't have ready-made ET tubes, tracheostomy tubes, you can make this makeshift like this. The regular ET tube, you can trim it and make it like this. And we are prepared for emergency cricothyroidotomy and immediately pass this. Now I will show that clinical scenario, that video. So let me summarize very clearly. In adult tongue-based lesions and pediatric laryngeal inlet pathologies, which are almost obstructing the laryngeal inlet in subglottic cases. That is the situation of no intubation, no ventilation problem. How to prevent the crisis? By high flow nasal oxygen, and be prepared for the emergency cricothyrotomy, and be prepared with the needle tracheostomy. I mean needle passage of needle into the trachea and connected to the oxygen. That is prevention. Suppose if you cannot anticipate it beforehand itself, and if you are unable to intubate and unable to ventilate it, that means you must observe the chest rise after giving scoline. If there is no chest rise, immediately you have to do stab and then pass this simple regular ET tube. We have to save the patient. Somehow we have to save the patient. So even though you are ENT surgeon, always when anesthesia is giving scoline and induction, when they are doing induction, you have to stand by beside the patient. You yourself also observe the chest rise. You must know how to observe the ventilation. You must observe the ventilation, chest rise. Even after passing the ET tube also, even though you are an ENT surgeon, you yourself has to auscultate all the lung zones, whether that has gone to right or left, or whether every area is equally ventilating or not. So that is your job also. And for every change of position also, like this in tonsil positions or whatever in ear surgery, I have seen some other surgeons doing simple meringoplasty. They are doing under general anesthesia, and the surgeon is rotating like this, and the tube has come out and the child died. So for every change of position, you have to auscultate. You must notice the chest rise. Never dependent on your electronic gadgets, these pulse oximeters. Clinical is more important than our electronic gadgets. You must observe the chest rise. You must observe the fogging in the ET tube. You yourself has to auscultate for every change of position in any surgery, any specialty. It's the funda. So that is how thing is. Now I will show you the real clinical picture, how the pathology is. Thank you. See, this is the pathology, multiple laryngeal papillomas in a 5 years child, almost obstructing the laryngeal inlet. So here we have chosen spontaneous ventilation by propofol and fentanyl, and then under spontaneous ventilation, that means the child became calm and he is maintaining his saturation with his voluntary respiration. He has not paralyzed with scoline. Scoline should not be given in these situations. Suppose if you give scoline and if you cannot intubate and the child is unable to ventilate, if the anesthetist unable to ventilate, death may happen. So don't give scoline in these situations, laryngeal inlet pathologies, and subglottic stenosis case also, and sleep apnea case also. So maintain the spontaneous ventilation with propofol or dexmedetomidine, that is according to your anesthetist choice, and then under spontaneous ventilation you intubate it, and without giving scoline you directly give vecuronium. Okay, this is the pathology. There is a small opening here, and almost this multiple laryngeal papillomas fill the whole laryngeal inlet. So undersize tube, the anesthetist paused under spontaneous ventilation. Initially he has seen small opening, so he has kept the tube like here, and and the child is, when the child is coughing under spontaneous ventilation, he kept the tube here, and when he get the another cough, he immediately passed. So that cough he utilized for intubation. He will explain in his video. Okay, this is very important, the intubation under spontaneous ventilation. Okay, thank you. In this case, the child with when the surgeon Dr. Sasidarth Tathavarthi, when he is changing the endotracheal, tracheostomy tube, he has kept high flow nasal oxygen, simple, our routine cannula, what we see in ICUs with 10 liters into the nasal mask, in the nasopharynx, and when he is changing the tube, he is getting some more time, he is getting some more apneic time. So, and the saturation, see the saturation, it is 64. So at 64, this nasal cannula, simple our routine 10 liters cannula, humidified oxygen cannula, it is helping him. But actually what they say is there is another separate instrument is there. This is not the advocated one, but Sasidarth Tathavarthi, Dr. Sasidarth Tathavarthi, who is a pediatric ENT surgeon, he has done like this. So somehow in where we don't have that nasal high nasal flow oxygen flow instrument, when we don't have that instrument, we can get some more time like this. From boils also you can get this, and you can press the emergency oxygen button. See, simple cannula like this. He kept in the nasopharynx and then he changed it. So that is how we can do this. See, there are two things in anesthesia. One is spontaneous ventilation technique. Another is apneic technique. These two are very important for our ENT surgeons. Spontaneous ventilation means when you anticipate no intubation and no ventilation, first you will do the spontaneous ventilation. That means the child become calm and he is voluntarily respirating. That means respiratory muscles are still active, and the patient by himself is maintaining oxygen saturation 100%. Just the patient became calm and the respirations are still moving. Respiratory muscles are acting and the chest is moving. That is spontaneous ventilation. Another is apneic ventilation. That means when we are doing subglottic stenotic cases, what we do is, initially we may keep our ET tube at the laryngeal inlet area and make the saturation 100% and wait for some time, or even laryngeal pathologies also, you intubate it, or in difficult intubation cases, at least at the laryngeal inlet or just below that, you can keep ET tube and maintain 100% saturation and remove the ET tube, and then you can work at that area. That is apneic ventilation. That is different. In another video I will explain what is apneic ventilation and what are the clinical uses. Let us restrict a spontaneous ventilation in this clinical scenario. So in apneic ventilation, you can keep a direct laryngoscopy. When you are working at the subglottic area, you can keep a direct laryngoscopy and you can pass the ET tube in the direct laryngoscopy and inflate the bulb and maintain 100% saturation for some time and remove the ET tube, and you can work in that direct laryngoscope by apneic ventilation. When the saturation is coming 92, below 92, again you keep ET tube in the direct laryngoscope, or directly you can keep in the trachea and wait for 100% saturation oxygen and wait some more time and then remove the tube and you can work in that area. That is apneic ventilation. Spontaneous ventilation, apneic ventilation. These two techniques are wonderful techniques for our ENT surgeons. That apneic ventilation I will explain in another video. So this is called thrive. This is thrive, in where you can face a difficult no intubation, no ventilation problems. Dr. Anil Patel, he is Indian origin only. Now he is working in England. He has discovered this, and Dr. Rakesh Srivastava from Lucknow is doing a lot of work on this thrive. So thrive means a transnasal humidified rapid insufflation ventilatory exchange. It is there, that the whole video is there in the YouTube. You can go through that. So this is thrive, high flow nasal oxygen. That I will show that also. See, high flow nasal oxygen and thrive by Rakesh Srivastava. You can get that video also. You can go through that. So when we don't have this high flow nasal oxygen needs separate instrument. Let me show you like this. Separate instrument is there to pass the high flow. So you go through that video, you can get everything. So that is another thing. See that instrument, see that instrument. Okay, when you don't have that instrument, what Dr. Seshidhar Tathavarthi has done is simple our oxygen ICU oxygen high flow is there na, that he has kept just tube in the nasopharynx of the child and he exchanged. So he is getting some more time. You can get that also, thrive high flow humidified oxygen by Seshidhar Tathavarthi, that video also. But actually this is not prescribed. Dr. Seshidhar Tathavarthi has done it. The prescribed, now the heavy research is going on. Now Dr. Seshidhar Tathavarthi is doing laryngomalacia and so many laryngeal pathologies without intubating. He just maintaining 100% oxygen and he is getting a lot of time by just high flow nasal oxygen cannula. So this was initially proposed by Dr. Anil Patel and Dr. Rakesh Srivastava from India. He is doing a lot of research. So in this no ventilation, no intubation and no ventilation cases, when you anticipate the situation, especially regarding my case, the multiple laryngeal papillomatosis in a child of 5 years, where the child is in stridor. So in such a situation, doing tracheostomy is also difficult. So once you make a child calm by propofol, you try to intubate rather than doing tracheostomy. So always try to intubate it. So you try to intubate rather than doing tracheostomy. Whereas in adults with the sleep apnea, when you anticipate this situation where you cannot intubate and you cannot ventilate, you can do tracheostomy. In adults it is not a problem. Adult patient will cooperate. So you can do tracheostomy even just with the local gelacaine, and then you can induce the patient through this tracheostomy tube. So adults it is not a problem doing tracheostomy. Whereas child may not cooperate. So anyhow, to make cooperate the child, to make calm that child, we have to calm that patient, that child with the propofol. So then try to do the intubation rather than doing a tracheostomy. If the emergency happens, we cannot do anything. You have to do directly poke in the cricothyroidotomy with a blade, and then you immediately insert a endotracheal tube through this tracheostomy opening. Otherwise the patient will die. So that is an emergency. So finally my message is, in children where you cannot intubate and you cannot ventilate situation, when you anticipate that, you give propofol and maintain the spontaneous ventilation and try to intubate it. In such a situation, doing tracheostomy is also time delays, or if the propofol dose is a little bit more, respiratory movements will decrease. So it becomes a crisis situation. Somehow you try to intubate it. If you cannot intubate and you cannot ventilate, there is no option. You have to do emergency cricothyroidotomy. So it's a very tricky situation. So when you give propofol, you try to intubate it. If you cannot intubate it, try to ventilate it and then do the tracheostomy. If you cannot ventilate also, do the emergency cricothyroidotomy. That is the point I want to stress. Thank you.
Ideally,
Sir, please.
Ideally, induction of a patient in a case of laryngeal papilloma has to be done with inhalational induction, especially in a pediatric age group. That too with sevoflurane. And once the patient is taken into a deeper plane with sevoflurane, then the anesthetist has to do the scopy and he has to see the feasibility, how much is the laryngeal inlet opening, and then decide on the tube and intubate the patient carefully. Since regarding the case which we have done recently, the place where the surgery was done was not having sevoflurane. It has only isoflurane. Isoflurane, by nature of its smell, it is bit tingent. Pungent odor will be there. So babies will not tolerate the pungency. So I have chosen an option of IV induction with propofol and fentanyl, and without any muscle relaxant. After the patient is sedated, I have taken into a deeper plane and then done the scopy, and I have seen the laryngeal opening. I am able to see the aperture, but laryngeal inlet is not visualized because it is masked by the papilloma, which was arising from the right.
A little bit louder, sir.
Because it is arising from the it is masked by the papilloma, which is arising from the right vocal cord. So what I have done, when I have done the scopy, baby was bit came into a lighter plane and the baby had a cough. So when baby had cough, the laryngeal papilloma was lifted up. Then I could see a small hole at the place of the lower end of the laryngeal inlet. So I have parked the endotracheal tube near that place, and I have waited for the child to cough again. Once the baby coughed again, then immediately I could pass the tube into the space which was just below the laryngeal papilloma.
So you have
passed 3.5 size undersized micro cuff tube intentionally, so that it should not traumatize the vocal cords and the papilloma.
Sir, why you have chosen propofol and fentanyl? Why you have not chosen dexmedetomidine?
See, there is nothing like it depends upon the choice of the anesthetist. Dexmedetomidine, to take into a deeper plane, it has to be started little bit before only, and it has to be given at the rate of 1 microgram per kg.
How much, sir?
1 microgram per kg.
Okay.
Dexmedetomidine we are supposed to give. But if you give 1 microgram per kg without giving anything, there are chances of baby having bradycardia and hypotension also. So the same work can be dealt with propofol and fentanyl, which are equally potent and equally short acting. So I have selected propofol and fentanyl, and the bradycardia episode won't be there with propofol. So I have selected.
So when bradycardia comes with dexmedetomidine, and when we are unable to intubate, the hypoxia also comes. So the bradycardia and hypoxia
We will not be able to differentiate it.
will not be able
So whenever you use, there is nothing like we should not use dexmedetomidine. We can use dexmedetomidine, but with caution, keeping an eye on the pulse rate.
So you want to say is the bradycardia and hypoxia both are too hazardous.
Yeah.
And what you are
There is
saying is
nothing like we should not give dexmedetomidine. It depends on the preference of the anesthetist and the scenario what we are dealing with. So in that scenario, we have selected.
what is the meaning of we cannot differentiate between bradycardia and hypoxia? What exactly is that?
No, not differentiation. Suppose we are giving dexmedetomidine. Suppose we are giving dexmedetomidine. The natural tendency of this dexmedetomidine, it will cause bradycardia. Suppose we are giving. Suppose we are not able to intubate, and because of hypoxia, hypoxia also will in turn will cause bradycardia, and both bradycardia is very hazardous to the baby. So the thing is, I thought we will avoid dexmedetomidine and go for regular propofol.
Okay, this whole thing is a spontaneous ventilation.
Yes, sir. It is done and done spontaneously.
Okay, thank you, sir. Thank you.